Hello, welcome to this lecture. This is a topic on the pediatric cases for chromosomal disorder. I'm Josephine CHONG. I'm a pediatrician and clinical geneticist in Hong Kong. So welcome for those who's joining us online also. So in this lecture, I'm going to share with you some of the chromosomal disorder, and I will also go for like a background revision for the simple syndromic disorders. So just now I've talked about presentation of syndromic disorder. You can make clinical diagnosis without genetic testing. Yes, we can do that by physical examination and also history taken. So to start with, we can see this is a cell. So you can see this is a karyotyping. So for chromosomal disorder, we are talking about a sizable copy number variant. It could be a duplications, it could be a deletions, it could be a whole chromosome which is duplicate, which is the trisomy or the monosomy or other structural rearrangement. So in the past with the karyotyping, which is what we call karyogram. So you can see on this slide, you can see a karyogram that we can identify the structure of the chromosome under a microscope. But nowadays, with the techniques and advancement, we can not only see the large copy number variant, but also the smaller one with different testing, including the microsomal array, the chromosomes and pseudosets. Of course, when we are talking about chromosomal abnormalities, we can see that patient may have different physical features, clinical presentations. It's all because of the gene on the chromosome, which is related. So chromosome 1 had more than several thousand genes. So if you're talking about like the whole 23 sets of chromosomes, there are more than 20,000 genes involved. So one single chromosome has several thousand genes. So if there is a trisomy, for those involving a large, long chromosome, usually those patients will be more severely affected. So those fetus may not have a normal development, may have an early miscarriage, and also may not sustain. So we usually seldom see those live birth with this kind of molecular testing. But then for those patients presented with recurrent miscarriage, sometimes we do see if it's an early miscarriage, we got the POG for genetic testing, including chromosomes, then we may identify this group of rare chromosomal disorder. So in that case, this is a very, very early chromosomal disorder presentations. So you can see for chromosomal 1, there are more than 4,000 genes are there. And then you can see 21, which is the Down syndrome that we all know. Down syndrome is involving 21 chromosome. This chromosome is relatively short and only involve around like 500 genes. So that case, some of the patients could survive until birth with different abnormalities. So you may not able to encounter some of the chromosomal abnormality. It doesn't mean that those disorder will not occur. It will occur, but then it's just that they will not develop further. So chromosomal disorder could have a numerical abnormalities, including the aneuploidy, monosomy, triploid, trisomy, tetraploidy, and it could also present with structural abnormalities with deletion, duplications, inversion, translocation, ring chromosome, isochromosomes, or other smaller copy number rearrangement. So genetic testing, besides karyotyping, microsomal array, FISH testing could also be used for confirmations in some of the situations. Pseudosets and chromosomes are techniques of using an NGS testing to see a smaller copy number variant. And all these testings are testing for copy number variant, whether there is any copy number gain or copy number lost. So we understand that in for example, trisomy, it is due to the non-disjunctions at meiosis. So the common chromosomal syndrome caused by non-disjunctions, including Down syndrome, Patau, Edward, China syndrome, and Klinefelter. So among this list, Down syndrome, China syndrome, and Klinefelter syndromes are the more commonly seen conditions. And with the NIPT, nowadays we seldom see Down syndrome, but then there were still false negative NIPT conditions that we will see a live birth of Down syndrome. And also prenatal diagnosis of aneuploidy, in the past they have used different methods to try to increase the percentage for getting yield. I'm not an obstetrician, so I would say usually when the patient referred to us, the patient already had done an invasive diagnostic testing, including CVS testing or immunocentesis with genetic testing. So in that case, if an invasive molecular testing had been performed, usually the diagnosis would be close to 100%. We are talking about chromosomal abnormalities. So different papers have quote about the different sensitivity and also the specificities of NIPT testing. But then the most important thing is that we have to understand it is not 100%. And also there are limitations and also false negative conditions case reports do occur. And then the pre-testing genetic counseling is the most important part in this regard from the point of view of clinical geneticists. So getting basis of the Down syndrome, first of all, most of the patients will have abnormal facial dysmorphism with apicanthic folds, upslanting eyes, upturning nose, flattened nasal bridge, and nose at ears. So it's very typical and also easily recognized. And patients may have a single palmar crease and wide sandal gap. And some of the patients, even if they have a false negative NIPT, some of them could already present with abnormal congenital structural heart problem, which could be identified by the antenatal structural ultrasounds. And some of the patients represent a birth with duodenal atresia and also Hirschsprung disease, which sometimes is difficult to identify during antenatal period. For Patau syndrome, it is a trisomy 13. This group of patients in the past, usually people say it is lethal. Lethal in a way that it's because the patient will have a holoprosencephaly, and those patients usually could not maintain a good cardiac and also a respiratory functions, so they will have an early death. And patients will have microcephaly and also will have different structural abnormalities and also congenital heart defects. Edward syndrome is another syndrome which also covers the trisomy 18, is also most of the time covered by the NIPT. And patient will have a very typical clinical features, which what we call a rocket bottom feet, and also the overlapping fingers and a small head. So in the past, before NIPT, we do see some of the patients presented at birth, and the obstetrician will call in the pediatrician to go to the labor ward, and then this kind of clinical features already could make the diagnosis. And in that case, we will do a very fast test, which is a qPCR, just to confirm the trisomy. So as fast as possible, because the turnaround time do matters, that we can counsel the family as early as possible about the conditions. And for Klinefelter syndrome, which comparatively is more common than the other two syndromes that occur in 1 in 5,000 live birth. So in the cohort, it mentioned about low intelligence, but some of the patients may have a normal borderline. And then some of them may not been identified at the early age, but later on with tall stature and also maybe behavioral or psychological problem, or even with just infertility. Some of them may be detected quite late with infertility. And for this group of patients, the hormonal treatment is also important. Partial chromosomal deletions involving different chromosomes also could occur. Some of them may have a terminal deletion of the short arm or the long arm. And for this group, it's a 4p minus. So this group of patients may have typical features of hypertelorism. You can see the distance between the two eyes is a broad nasal bridge. And then cut lips, some of them may have cut palates, a down-turning mouth. Josephine syndrome is involving the 5p, which is terminal deletions of the short arm of the chromosome 5. Patient will have a microcephaly and also a very typical cat cry, which is an abnormal cry noise, which is related to the abnormal development of the glottis and also the larynx. And for this group of patients, they have hypotonia and growth hormone deficiency. For the growth hormone deficiency, it could be treatable, but then if the patient had severe congenital structural abnormalities, which is the predicted, which is actually the assessment could predict like the expected life expectancy of the patients. And then here comes the Prader-Willi syndrome. Prader-Willi syndrome had different clinical features depend on the period for presentation. During infancy, usually patient presented with failure to thrive, severe hypotonia. So in that case, during that period of time, usually underweight. And later on, because of the abnormal feeding and eating patterns, patients will have overweight. And also, usually you see patients who have typical facial features with almond-shaped eyes, rapid smiles, and also by temple narrowing is the distance between the two temples will be narrow and very small mouth, and they may present with learning disability. It could be due to parental deletion of the chromosome 15q11.2, or it could be due to parental disomy and methylation defects. And Angelman syndrome, very typically patients presented with delay and very severe speech delay also, and very wide mouth and ataxic gaze. So while we see the patients at the pediatric clinic, if the patient walking with ataxic gaze and very wide mouth and very happy looking, then we already got a clinical diagnosis of Angelman syndrome. And then during history taking, we were asked whether the patient had any seizure or any epilepsy or not. So all these different types of syndrome, in the past we used the syndrome, the word, is mainly because the diagnosis is made based on clinical assessment, based on the clinical features. Some of the patients may have chromosomal diagnosis by using the karyotyping, but then some of the patients may not be able to achieve. So in the past, we have this ISCN nomenclature. I think Dr. Sauer, Professor John already covered some of the cytogenetics areas. So you can see that different time, we have a different version. So that means with the advancement of genetic testing, you can see more and you can see more clearly to the small structural abnormalities. So with different version of nomenclature, sometimes when you get back the cytogenetics result of the patients, you may not be identified the exact segment. Then you need to get back to that exact version to see which segment it is referring, and then to correlate with the new version of ISCN to see if there's any changes. So in the past, we just say cytogenetics, but nowadays we use the term cytogenomics nomenclature. So the latest one is the 2020. And some of the patients may have very clear-cut trisomy. Some of the patients may have a mosaic conditions, which means if you're doing a karyotyping, some of the cells may have a normal 46 chromosome. Some of the cells may have an abnormal number with trisomy. And if we are doing a karyotyping, usually we will count the number of cells, then we can get a projective percentage. That kind of projective percentage is representing the specimens that you have taken, but it's not representing the percentage in different tissue types. So with the mosaic conditions, there is a range of clinical presentations. Sometimes you cannot use the percentage number by karyotyping to predict like whether the prognosis is good or not. This is a pamphlet for laymen, for patients to read, which is a UK website if you need. They have different chromosomal abnormalities, including what is the abnormal structure, what is the clinical features, and what had happened to result in this abnormal structure. I think this is quite a useful resources for you while you're talking to patients using layman terms. You can also, some of the patients, if they would like to know more about the details, they can, I think it is readable to a layman level, so you can override them. So for fish testing, they have also got different nomenclatures. Different nomenclatures you can see is representing the short term, is representing different happenings in the chromosome. I think Professor Chong had already covered the nomenclature, so I'm not getting into detail. So just to share with you a few cases related to the chromosomal abnormalities. So this is a 10-year-old girl presented with short stature. So this patient do not have Benaki yet at that time. And then on physical examinations, patient is 2 cm below the third centile. And there's no obvious facial dysmorphism except a low posterior hairline, and there's no signs of puberty yet at that time. So which genetic testing will you offer to this patient? So option 1 is NGS testing for short stature. Option 2 is panel for delay. Option 3 is karyotyping for a soft skin related to short stature, and 5 is a whole exome sequencing. So patient is a 10-year-old girl with short statures. I think, first of all, we need to get back to a detailed history taking to see if this patient had any other clinical history of developmental delay or other system involvement. Okay, karyotyping, yes. So we have done a karyotyping. So the karyotyping comeback is 4666. Normal. So what is your differential diagnosis when you think about karyotyping for this presentation? It's a very, very common presentation indeed, I think, for clinicians to encounter. Yes, we think about, we need to rule out parent first. So we offer a karyotyping. So karyotyping come back. So what will be next? Getting back to this list. What will be the second test we would like to offer to this patient? Whole exome. What else? Yeah, maybe it is a good choice. Thoughts? Yes, NGS panel. So actually, I have no correct answer to it because the history is too short for you and the physical exam is not comprehensive here. So we're getting back to take a look of the girl. So we need to think about, first of all, we think about Turner, how we think diagnosis is. So at that time, we think the karyotyping is negative. Getting back to the history and also the exam, still think that the patients may have Turner syndrome. So in that case, we have to count a number a little bit more cells. So find out actually the patient had mosaic Turner. Mosaic Turner is a little bit tricky. The patient will not present with all the features for Turner syndrome. Some of them could present with delayed menarche. Some of them may have just short stature, and some of them may be without all this, just borderline behavioral. So this is a typical features of Turner syndrome. So you can see the prevalence is quite high. 1 in 2,000 and 1 in 2,500 live births. So when you're talking about typical Turner syndrome, it's approximately 90% with 45 chromosomes. So 99% of all 45 chromosome conceptions are miscarried, but then mosaic is also common, around 30% of them. So they can have different level of dysmorphism. Besides short statures, they may have web net. Web net sometimes is very difficult to identify if it is not that obvious. Broad chest, low hairline, the cubitus valgus, and also shortened fourth metacarpal. So usually when we see a patient with short stature female, we will immediately check the head, check the hairline, the ears, and then the neck, and then down, and then show the hands, and then ask them to make a fist, and then we will check the lower limb to see if the patients have lymphedema, and then we'll check the back to see if the patient has scoliosis, and of course, systemic review, including the auscultation to see whether the patient had any heart defect is also important. For the history taking, we'll ask about like the menstrual cycle, and for older patients, we'll ask about fertility. So we can see in different papers the facial features of Turner syndrome. Actually, I would say sometimes some of the patients, if they are having mosaic Turner, it's very difficult to identify, and also depends on which group of patients you see more. Because for facial dysmorphism, if it's not the ethnic group that you see more in your practice, sometimes it's, your detection rate will be lower in terms of the physical exam skills. If it is another rare ethnic group in your community or in your practice, sometimes missing a patient with low grade of facial dysmorphism is common. But lymphedema is relatively easy to identify. So you can see lymphedema is quite obvious, and the edema is non-pitting. And this is one of the features that could help you to identify, especially for those patients with mosaic Turner syndrome. So 75 to 80% of the single chromosome is from the female egg, and the non-disjunctions of mitosis at early embryonic stage have already happened. Low positive predictive value for the Turner syndrome in NIPT. I think this is a well-known phenomenon, is that because like the false positive from monosomy sometimes could be related to different conditions. It could be a confined placental mosaicism. It could be a twins demise, but more importantly, is a maternal age is also an important factor as well. It could be a maternal mosaicism. And aging is actually a normal phenomenon. In those cases, the mother may have a very low level of somatic loss of single X chromosome. In that case, that could lead to false positive monosomy X screening test. So for the treatment for patients, if you can identify those patients early at the age of 4 to 6, actually growth hormone could help them to achieve a taller stature. And patients also need to receive the hormonal replacement therapy as well. And for the genetic counseling, after we have made a diagnosis, we have to also refer the patients to assess. So Turner patients is a group of patients that you can't miss to assess, to refer her to a cardiologist for assessment. Because if even the physical examinations that you cannot detect any murmur, it may mean that the patient may be not suffering from any major structural abnormalities. But having a diagnosis of Turner syndrome or mosaic Turner syndrome, actually those patients will have a high risk to develop hypertension, and also will have a high risk of aortic dissections at young age. So the life expectancy for Turner syndrome patients is actually mainly related to the cardiac presentation of the patients. Okay, so case two is a patient with normal spontaneous delivery, 2.6 kilogram with normal ACA score. Antenatal was unremarkable. The antenatal genetic screening was also normal, unremarkable. The patients had non-consanguineous Chinese parents and a 3-year-old elder brother who is healthy. So the patient presented with easy choking for 10 days, at 10 days old, with poor feeding and also central hypotonia. So on physical examination, this patient's growth parameters were normal at that time. Patient had hypotonia, which is a central hypotonia with no obvious facial dysmorphism. The metabolic workup for this patient was normal, including lactate, CK, and Pompe enzyme. So why have I mentioned the CK and the Pompe enzyme? Because for patient presented with cross-motor delay or hypotonia, actually, there are conditions that we couldn't miss, which is the Duchenne muscular dystrophy and also Pompe disorder. Because these two groups of disorder are very treatable for the Pompe disorders, actually, a patient could receive an enzyme replacement therapy every 2 weeks, and the outcome will improve significantly in terms of the skeletal muscles power and also the hypertrophic cardiomyopathy usually will resolve with the enzyme replacement. And for Duchenne muscular dystrophy also, that you have to identify early because they can receive treatment and also they need to have a cardiac assessment as well. So the key features for this patient is hypotonia and poor feeding. So we have to keep the Duchenne and also Pompe in mind. We have checked that, which is normal. Then we have to work out for the hypotonia. So what will you do next? So you can see this list with karyotyping, array methylation testing, whole exome sequencing, whole genome sequencing, or mitochondrial sequencing testing, and SMA gene. So SMA is another condition that we need to talk about in the whole lecture. So SMA patient will also present with muscle weakness. So this patient at 10 days old with feeding and hypotonia is very, very, very relevant to check for SMA, because SMA nowadays is treatable. And the earlier the treatment is, the earlier that we can save the function of the neuron. So for SMA right now in Hong Kong, CHK offer SMA newborn genetic testing. So this case presented before the era for newborn genetic testing for SMA. So you can see that the patient also have poor feeding. So I've mentioned about other syndromic features that patient will present with poor feeding. So for pediatrician, very difficult. There's no pediatrician here. So if we have a case presentation with poor feeding and hypotonia, we think about that, whether this patient is suffering from the condition that we need to check for the chromosome 15. So in this case, we have done T2C, which is an NGS testing to check for copy number loss or copy number duplication. So this patient had a chromosome 15q11.2, Q12, approximately 4.5 megabase size lost. You can see from the report that they mentioned about the band and the starting point of the genomics locus and the endpoint and the size and what are the list of the genes which is involved in this long copy number loss. So this patient had an interstitial deletions of this. The parental copy are normal. It is a de novo finding. We confirm. The MLPA confirmed that it's paternal deletions of the 15q. So the diagnosis is Prader-Willi syndrome. So as I've mentioned in the previous slide, Prader-Willi syndrome, early phase the patient will not present with overweight, usually with hypotonia and poor feeding. So later on with the abnormal behavior, with excessive intake, then they will present with overweight. So this mother was referred to genetics clinic. And when she heard about the Prader-Willi syndrome diagnosis, she was furious. And she told me that she wanted to sue the ONG doctor because that the patients have been over NIPT testing for the as an antenatal genetic testing, that the patient mentioned to me that I have chosen not the ordinary NIPT, is the pro version, which the microdeletions syndrome should be included. And I have checked the list of disorder. Prader-Willi syndrome is also there. This is what the mother had told me. And then I say, first of all, you need to give me the report first. I have to check whether you're talking about that exact testing. And then I have to see what have been done, because if it is an NRPD, just check for trisomy 21, 13, and 18, then I have to explain to her that actually this is not covered. But find out that the Prader-Willi syndrome is also covered in the list. So can the patient initiate a medical legal action towards the obstetricians? So what do you think based on this genetics result, if the patient asks you as a geneticist? So that means something wrong either with the lab or with the obstetrician, right? So, and in that case, so I have to check. So you can see in the different laboratory, actually there is a sensitivity of detections. Then after the patient is out, I immediately call the obstetrician to ask whether you have given the patient a pretest genetic counseling. And she said, yes or no, because usually this kind of testing is covered by the nurse to talk about what covered and not to a very detailed. And then the limitation of the testing was not informed, and also the possibility of false negative result is not informed. And just mention about sensitivity with certain percentage. I think at least it's good that they have mentioned about sensitivity is not 100%. For microdeletions, it's even lower than trisomy. And for this case, because the size is not bigger than 5 megabase, and that laboratory had only a detection ability to check for the size bigger than 5. Most of the laboratory nowadays could check for a size maybe above 3 megabase. So if that patient had chosen a laboratory with a size 3 megabase, this condition could be identified antenatally. And then the next question is that the patient asked me, so the doctor did not offer me for checking the NRPD at another lab with a higher sensitivity. Is there any issues of like the negligence or liability in terms of explaining the power or the ability of testing? So what I could say at that time is that as a doctor, we cannot introduce all the tests all over the room. I don't know what has been explained to you by your own doctor, but then all the tests will have its own limitation. So in your situation, the laboratory report is correct because they cannot detect the size, copy number, deletions. So there is nothing wrong with at the laboratory side, right? And also, I can't say whether the obstetrician is right or wrong. I say if they have already explained to you about the sensitivity is not 100%, even though they may not explain to the detail about the size because it's not layman ability to understand sometimes. I don't think that actually had very, very, very big issues. So I think getting into a pre-test genetic counseling, if the patient's ability could understand more, can explain more, is better to encounter this kind of case. So later on, we have settled down the patients, and then we have to also understand for different types of syndromic disorder, even though it is covered by NRPT, but then the most important thing is also to mention about the possibility of a false negative result and also the limitation of the testing, and still is just a screening test. Okay, so back to Prader-Willi syndrome. So Prader-Willi syndrome, you can see the DNA methylations abnormalities. So it is normal, is very unlikely, it's a Prader-Willi syndrome, and then it's abnormal, and past we do methylation testing, we can see whether there is any uniparental disomy or whether it could be due to other genomics happening or events. And for Prader-Willi syndrome, it may affect different regions, non-imprinted region, the Prader-Willi region, and also the Angelman syndrome region. You can see that there are other single genes which is involved in the Angelman syndrome and also the Prader-Willi syndromes. So in that case, sometimes with different genetic abnormalities, patient may also could present with similar features as the two syndrome. Okay, here comes the third case. So this case is a female term baby, antenatally had increased risk of Oscar and with increased leucal thickness. The amniocentesis was offered by the obstetrician, and the karyotyping came back is normal, not normal with a Mosaic Turner syndrome. So at that juncture, the antenatal genetic counseling was over. So what had been delivered to a patient is that the clinical features and the possibility of the range of the phenotypes for mosaic Turner syndromes was well explained to the family. So if the patient presented to you in Hong Kong, the legal age for termination of pregnancy is 24 weeks gestation. So if the result of amniocentesis come back before 24 weeks gestations, we will see the patient the next day, because so that we need to ensure she has enough time to consider for termination of pregnancy. Patients can consider termination even on 23 weeks, 6 days, but not on 24 weeks gestation. Okay, so with mosaic Turner, as I mentioned, there is a big wide range of phenotype presentation. For this family, they have chosen to keep the patients because this is a precious baby, and also quite difficult for them to get pregnant at that time. And postnatally, the patient presented with significant hypotonia and also head lag and 1.5-year-old. So if you think about these clinical features, do you think it is compatible with Turner syndrome? So this patient was seen by me, I think 1.5-year-old. So at that time was seen by several doctors before that. Also mentioned about mosaic Turner. So when we are following a patient with already a diagnosed genetics condition, usually we need to check about the clinical features, whether it is compatible to the previous genetic diagnosis or not, and also whether the progress is compatible or not. This patient with the significant hypotonia and also head lag at 1.5-year-old, actually I have videos, but just now that PowerPoint cannot be shown the videos today. The patient still have head lag at 1.5-year-old, which is really significant. And I think the clinical features is not compatible with Turner. So we need to know whether we should go for a second genetic testing. So at that juncture, we think that the clinical presentation could not be explained by the karyotyping. So we have done a whole exome sequencing for the patient and find out that the patient had a compound heterozygous variant on the TH gene. So VLS, for your information, is a variant of unknown significance. That means we identified 2 variants on 2 arrows, but then we don't know whether it is a disease-causing variant or not. So at that time, we do further structural functional testing. So TH gene is actually one of the IEN disorder which involve the CNF neurotransmitter, which is the Sagawa syndrome. So for those patients presented, usually they will present it with a motor abnormality. Well, for example, they could present it with delay, they could present it with different types of abnormal gait, and patients could not walk. And this patient is quite young, is 1.5-year-old, and is still with significant head lag. So if it is a TH deficiency, it could be quite a severe case. And so we have to confirm whether the 2 variant is disease causing or not. We cannot explain by molecular method at that time. We need to do a CSF neurotransmitter. And later on, we confirm that, and then we treat the patient. We do a lumbar puncture for neurotransmitter, and then we treat the patient on L-DOPA. And just 3 months after we have treated the patient already could sit upright with no head lag. And then later on, the patient could even walk after 6 months treatment. So if the patient around 2.5-year-old come back walking for follow-up. So the parents were very, very happy because like since birth, up to the age 1.5, they think that the patient is suffering from mosaic Turner. And then they accept that the patient has delay. And they they didn't know that they have actually delayed the exact diagnosis for TH deficiency. They did not attend any pediatric neurology to start with. And getting this diagnosis is treatable, and then actually the motor delay have been catch up by this patient. And I've got a video sent back by this parent that they have got a view cam at home, showing that the child right now, 3 to 4 year old, this child is jumping on the sofa, jump down, running around in the sitting room. And the father was happily laughing at the side. So usually while a parent see a child jumping like that at home, they will be very angry. But this father is very happily laughing at the side. They sent me this clip is that they also want me to, while we're educating geneticists or pediatricians, a second molecular diagnosis is not rare actually nowadays with the whole exome sequencing. We can identify quite a number of patients suffering from 2 molecular diagnoses. So while you're following a patient with a known genetic diagnosis, if the clinical features is not compatible or the progress is not compatible, try to think about what are the missing genetic testing that you have not offered the patient, because each of the genetic testing may have its own limitation. Each of the tools is only looking at that part of genetic abnormalities. So for these patients, they have done karyotyping only, which is a copy number variation testing. So the monogenic abnormality was not tested at that time. So that's why we have offered the whole genome testing. So if the molecular testing only check for the VUS, we need to move on to functional testing so as to make a diagnosis for treatment. So, so this is so much for this case. And the 4th case is that this patient is a prenatal case of 22 weeks. Ultrasound is unremarkable. And then the indications for getting an invasive testing at that time is an NIPT testing showing high risk of monosomy, chromosome 5. And later on, the amniocentesis showing that the chromosome 5 is actually normal, but the microsomal array is showing that there is a de novo mosaic duplications of chromosome 2, which could be a VUS, could be a likely pathogenic disorder. This is the last slide that I bring up this case to talk about. Is not to talk about like the exact clinical presentations for chromosomal 2 duplications. Is that we do see quite a number of patients with antenatal genetic diagnosis. So while we are approaching an antenatal genetic diagnosis, first of all, we need to see what are the testing, what is the specimen, whether it is a CVS or amnio, because for CVS, things do happen like the placental mosaicism sometimes. For amniocentesis, what are the testing and what is the finding? And for sometimes, because the advancement for the technology, we could identify like variant with unknown significance and which we do not have any antenatal structural abnormalities, and also no antenatal functional testing that we can assess whether the fetus is affected or not. So in that case, it all depends on the, first of all, which chromosome is involved, what are the genes is involved. So the genetics counseling should include, first of all, we need to explain to the patient side, this is a de novo finding, which is not occur in parents. That means the recurrence is quite low, except that there could be gonadal mosaicism risk. And then secondly is the involvement of the genes, and then the segment of the chromosome which is involved, and how many genes are there, what are the genes functions, and also what are the case series of the duplication at that area. For this case, that how will the patient present it, and then it's the interpretation of the variant that we have find out whether it is a disease causing or whether it is a VUS. And for VUS, we need to take in further considerations. Say, for example, it is not a copy number condition, it is a monogenic conditions. Actually, VUS is quite a wide range. In the past, we have classified variant into like 5 category, pathogenic, likely pathogenic, VUS, likely benign and benign. But nowadays, we are more or less towards to talk about like a spectrum. VUS and likely path, sometimes during the classifications, is very difficult to say. While we all classify this kind of variants most of the time, according to ACMG guidelines. But while we are talking about taking into the detailed look of how they classifies, what are the criteria in terms of like the PS, PM, or PP, sometimes without case report, it already upgrade or downgrade the variant to VUS or LP. So if we have evidence that that variant that we can predict further, like for example, that variant could upgrade to likely path or could probably downgrade to benign in the future if there are case report or if there are some more evidence in terms of functional or basic science study. So in that case, we can counsel the patients accordingly. But if we do not have that kind of backup evidence at our antenatal period, still we need to explain to the patient that this VUS, still there are possibility that it could be re-identified as likely path or benign in the futures. So in that case, you're not offering the family a very exact prognosis, but then it is the fact that we cannot do that at that juncture. So what we can offer is that if the patient is beyond 24 weeks, we can talk more about postnatal assessment. If this is before 24 weeks, then it is up to the family's decision if we have so much uncertainty. And we will not judge whether a termination of pregnancy is right or not in this case. So the role of the clinicians is mainly to explain about the clinical findings, the molecular findings, and also to offer the family to explain about like the questions. And then we need to also let them know about the limitations of our clinicians and also the current medical knowledge. The technology is already beyond our ability to understand for some of the findings, but that's the fact that we need to relay to the patients. Because what if the patients continue the pregnancy and later on, postnatally, this variant was upgrade or downgrade, then the prenatal genetic consultations and also the documentations are the most important evidence for what you have already mentioned to the family. So I think that's it for my case sharing for chromosomal abnormalities. I will stop here. So thank you for your attention. So I'll see if you have any questions.